next steps. But let's record the presentation. We have participants coming in now, and if people are arriving at the regular time, then we can. They'll be more motivated to go back to the beginning of the presentation on the recording. So, Alicia, do you want to start us up then?
Yeah, we're all set, Doug. I just hit record, so if you want to introduce Stan, and then we can go from there.
Okay. Welcome, folks. This is Doug McCall from the International School Health Network. Pleased to be facilitating this session, one of a series of sessions on different topics in low-resource countries. We're really pleased to be looking at mental health today. Mental health in the low-resource context is a topic that I think, needs more scrutiny and more discussion. In the context of high-resource countries, there's been a lot of work, as most people will know. But in terms of the low-resource countries, it is an uncharted set of uncharted waters, perhaps, and we need to focus in on it. Our presenter today, Dr. Stan Kutcher, is the Sun Life Financial Chair in Adolescent Health and Director of the World Health Organization Collaborating Center on Mental Health Policy and Training. He's an expert in adolescent mental health, and the programs that he's developed have been operating and tested in over 20 countries. His work today, I think, is going to offer some insights into how mental health programs and teacher training can be delivered in such countries. And he and his colleagues in those countries and elsewhere have successfully adapted both an instructional program and a teacher training program for mental health literacy. Stan, if you'd like to take over and make your remarks, and then we'll pick it up with questions and discussion. For participants online, if you'd like to post as questions come to you through Stan's presentation, simply post them on the chat board, and at the end of the session, I'll go back and read them out loud so we know which question we're addressing as we're going through the discussion stage. And then after that, I'll have a couple of slides looking at maybe some questions or issues or themes that we want to address in some greater detail if we have time. So Stan, please take us away.
Sure, thank you, Doug. Appreciate the opportunity to share with you all one of the projects that we have conducted in low resource settings, specifically in the country in youth mental health. And
Stan, please stay close to your mic.
Yeah, I am.
Okay. Sorry.
I'll increase the volume here, I think.
Stan, I'm sorry, we still can't hear you. It seems like
you... Can you hear me now?
Yeah.
That's better.
Yeah, okay, but except I lost the... window. Oh, here we are. Okay, I got it back. Okay, can you hear me now? And everything better?
All good.
Yes.
All right. Okay, great. So what I'm going to be focusing on in the mental health sphere is mental health literacy, which I just want to point out is foundational for everything that we do related to mental health. Just as we can't read a piece of writing in any language if one is not literate in that language, we really can't do anything effectively in terms of improving mental health if we're not literate in the field of mental health. So it's the foundation for mental health promotion, building of all the mental health competencies, prevention, and for care. All those things are founded on good mental health literacy. And without good mental health literacy, we just aren't successful at the rest of it, which is important to remember because in many cases in high-income countries, we have jumped over mental health literacy to a whole bunch of mental health related interventions and then realized to our dismay that without the foundation in mental health literacy, we're not getting the kind of outcomes that we would expect to have. So this does focus on mental health literacy. This is a description of a project that was, as I said, conducted in Malawi, Tanzania. 3 partners, my organization, teenmentalhealth.org, with Farm Radio International, and was funded by Grand Challenges Canada. So just to point out that the onset of mental disorders as opposed to mental health problems or socially designed difficulties really onsets primarily in the adolescent years. So you see here between ages 14 to 25. And we know that 70% of all mental disorders can be diagnosed before age 25, and that the global distribution of these disorders is across all countries, all states, and across all socioeconomic variables, including low-income, middle, and high-income states. That mental illnesses themselves are highly predictive of a variety of other conditions, including diabetes, heart disease, stroke, and of course are primarily driving the rates of suicide. Now, when we look at these 2 countries, Malawi and Tanzania, what we find here looking at the age distribution pyramid is that both countries are primarily populated by young people. And the challenge here is because mental illnesses begin in young people as those people age, because mental disorders are chronic illnesses, that those age cohorts take the illness with them through the lifespan. So although we are seeing substantive numbers and concerns with mental disorders in all these low-income countries, when we have an age pyramid like this, the negative impact of mental disorders will actually increase over time and not decrease over time as the population ages upward through the lifespan. So we know that we have to focus as effectively as possible on addressing these particular issues. Now, and that is why we argue very strongly that primary investment in global mental health has to be on young people, and that question just came up whether we have good data on mental illnesses in low resource countries. Absolutely we do, and yes, the prevalence is very similar to that in high resource countries, except for things like PTSD and conditions which are associated with failed states and with severe psychosocial adversity such as war, famine, etc. So we know that 70% of all disorders can be diagnosed before 25. The majority are mild to moderate in severity and respond well to treatment if it is begun early, and so we can enhance those treatments in primary care, and that providing early identification and effective intervention in young people has a good return on investment with a very good population dividend. As I point out here, decreased early mortality, increased labor force participation, and substantive improvements in productivity. So what we have applied here, although we are focusing on the schools, is that we have to remember that schools are not an isolated part, that schools, regardless of whether they're in high income or low income settings, are part of communities. They are part of potentially part of a pathway through mental health care for young people, in which many actors play an important role, and schools cannot think that they exist in isolation, and they should not be doing programming or interventions that are in isolation of the rest of the available community support and healthcare systems. So when we conceived this approach, we focused on 3 different components. Clearly the schools, absolutely central. We used a radio methodology to reach young people in schools and in communities, and we had to enhance capacity in local healthcare providers, because once you start addressing mental health issues in schools or in communities, and young people identify, or other people identify young people who have mental disorders, in this case we're focusing on depression, then you have to be able to provide the care that's necessary for them. So again, very important message is although schools are necessary, they're not sufficient for addressing this issue. And we chose depression because it's common, because it will soon be the #1 burden of disease in the world for young people. And our approach, as illustrated here, addresses schools, youth clubs in the community, using radio programming, particularly first-person storytelling, and then enhancing capacity in local community clinics, because you have to do all these at the same time. So we can't play this because we don't have the bandwidth, but those of you who are listening to this now or later, if you go and click on this, it'll take you to 3 different YouTube videos, which are a lovely description of this particular project in Malawi and in Tanzania. So I just want to show you what we find here, and this is the impact of these radio programs, which are a combination of radio drama like soap operas, first-person story accounts, concerts, modern music, and a call-in show with Facebook linkages for young people. We actually were able to measure the knowledge that young people have about mental health and mental disorders in both Malawi and Tanzania, and we were able to compare population knowledge in communities before and after the radio interventions, and we show that there has been a significant increase in the knowledge for young people as a result of these radio interventions. We also find that the stigma, which is a problem everywhere, the stigma decreases as attitudes improve, and we also see that as a result of these radio programmings, which are designed to be interesting for young people. The other thing, and this is also exceedingly important, is that the radio programs actually have significant improvements in young people advising others other young people to achieve help, to go and get help in the community if they have a mental health problem or mental disorder. And you see here in both Malawi and then replicated in Tanzania, which occurred a few years later, the impact is quite substantial. The impact is greater in Malawi because they had 3 years of radio exposure at the time of the data compared to 1 year in Tanzania, but nonetheless significant improvements in both countries. And this is a kind of a research intervention which gives us great comfort because we're able to apply it in one country and then at a later time replicate it in another country and finding the same results regardless of where it was applied, which means that it's more likely to be a true impact as opposed to not a true impact. And then we also find that for young people that they report themselves seeking help, which is a huge impact because of exposure to these radio programs. Again, 3 years in Malawi and 1 year in Tanzania, but in both places showing this substantive improvement. So now I want to take us into the schools, but first I just want to reiterate that the schools are essential, they're necessary, they're a core component of this approach, but they by themselves can't address everything that needs to be addressed. And so the radio programming is directed at the community because not only do young people listen to the radio programming, the whole community listens to the radio programming. And so it has a substantive impact beyond the impact of the radio. And those of you who go and look at the YouTube videos will actually see the impact of that radio programming on changing community attitudes and community knowledge, not just in young people, but in their families and in their communities. So now I want to take us into the school system. And here what we have done is we have adapted a Canadian design program of curriculum resources and teacher training. And we have adapted it in Malawi and in Tanzania with education experts and mental health experts. students and young people, and have created the version that we use now in sub-Saharan Africa, and it's called the African Guide. So the within school activities all are headmaster supported, and the schools provide resources for allowing the interventions to occur, basically meaning space in the curriculum so that teachers can teach the resource in the curriculum, and giving teachers time to take the training that's required to be able to teach the curriculum. It doesn't matter what country we do this work in, whether it's Canada or Nicaragua or Romania or Finland or Malawi. The teachers have to be trained because the baseline teacher knowledge and the amount of stigma that we find in teachers is substantive. The knowledge is poor, the stigma is high, and teachers cannot teach mental health literacy if they themselves are not literate in the mental health area and if they themselves carry a lot of stigma. So the teacher training is 3 days, and then later on, months later, as a refresher, and they use the African Guide, which I already described as being adapted from the Canadian version. Once the teachers are trained on the use of this resource, they applied the resource in their own classrooms using their own pedagogic skills. So this is not an intervention that needs fidelity in its application. In fact, it's designed not to need fidelity, and it doesn't matter where in the world that we do this work, the outcomes are the same. The intervention then is also linked to I've lost all the slides.
We're working on getting them back. We're not sure where they went, but Elise is working on it.
Okay, so the intervention is designed to be applied, as I said, by teachers who are using the hard copy resources in class. The resources are also all available online in modular form, but in low resource settings, online isn't easily available, so that hard copy is available and the teachers use that. The radio is available in low resource settings. As we all know, the radio is the primary means of communication. And so what we've actually done is we've embedded the radio programs into the schools using radio listening clubs. And so one of the ways that schools use this information is that the young people will listen to the radio program. The teachers will then teach a lesson around mental health using the African Guide resource, which is in their schools, and will link the teaching of the resource to the actual programming that's on the radio. And what this does is it generates tremendous interest amongst the students because they love the radio program. It's very youth-friendly. It's youth-designed. It's youth-inclusive, and so this causes, as I said, great interest, and the teachers are able to utilize the material that's in the program, plus their own material that they have from the African Guide, and they are then able to address the student learning in that way. So I'm just going to try to go back and just show the other components here. We also did a peer educator training model for senior students in schools, but it was done in Malawi because of funding restrictions. And then the other thing we did was that we fostered a hub and spoke model, which was that schools were linked to healthcare facilities, clinics in the community, and the headmaster's role in this was essential for making sure that the operational linkage happened, because if students self-identified or if teachers identified students who may have depression, what we tried to do was facilitate rapid access to the community clinic where we had already trained the health providers in diagnosis and effective treatment. So here is just some data from various publications showing some of the impact. This is in Malawi, and this shows the impact of the teacher training program. Quite a substantive increase in knowledge and quite a substantive improvement in attitudes, which is a decrease in stigma. So we're seeing highly significant findings, but also substantive findings. The Cohen's d in knowledge is 1.17, and the Cohen's d on stigma is 0.46, both of which are excellent impacts in their respective areas. And then we see here we actually have, this is the Tanzania data. It's from a publication of last year, and we see exactly the same outcomes in the Tanzania cohort with substantive improvements in mental health knowledge, substantive improvements in attitudes, and increasing comfort in being able to address the needs of young people as a result of this 3-day training intervention. The next slide actually shows some of the impacts that this has had because of the training. So the teachers go back, and then we come months and months later, and we survey to see what was happening. And we find that the teachers are able to actually identify students who have in need of mental health care related to depression, that they advise students to go and seek help, and that also that they themselves, this is really important because we have a substantive impact on teachers' mental health and on the families of teachers. So once the teachers have learned the material, not only do they impart it effectively to the students, but they also use it for themselves, and they use it for their families. And we have major enhancements and improvements in both teachers' mental health and in their impact that's positive in their own families. So this very simple intervention not only addresses student mental health and well-being, it actually enhances teacher mental health and well-being at the same time. In assessing what impact this has had on student outcomes, we used a teacher-centric reporting model, and this data from Malawi, published in International Journal of School of Cognitive Psychology, showing that as a result of the exposure to the curriculum resources, the students had substantively increased improvements, positive improvements in attitudes, that means decreased stigma, and substantive improvements in behaviors towards others, helping young people with emotional difficulties instead of shunning them, increasing help seeking for themselves, and supporting help seeking for others. So very, very marked behavioral positive outcomes from the intervention shown in the students. When we look at actual student referrals, so as a result of this, were teachers able to identify young people who may have mental health problems or mental disorders, and then were they able to facilitate referral to the local health providers whom we had trained? Yes, they were. The teachers most identified that reported they had identified students who had a mental disorder, and that they actually had advised students to get help, and the number of students that was increased that went for care was substantially increased, way beyond before anything any intervention had occurred. We also found out that in Malawi that most teachers identified between 1 and 5 students over a 6-month period, and this number here, 375 students identified in a 6-month period to obtain help, was so substantively higher compared to almost 0 prior to the intervention occurring. And again, one of the advantages of doing a replication study model in another country, we find almost identical results, slightly lower, instead of 95, 84%. The students, because it was a lower period of time. Still, this huge impact on identification and referral for care. The actual numbers, again, in Tanzania, showing that most teachers identify between 1 and 5 students, which is what we would expect in Canada. We would expect that in Europe, and we would expect that in Latin America, which is what we found there as well. And we're getting the same data in sub-Saharan Africa. So this is a figure looking at the impact over a year period. So we went back and looked, and what we see here is this very substantive, what we call additive impact, so that the impact doesn't occur and stay static. It actually increases over time, which is a good thing. And what Q1 is the number of students that were reached by the guide taught. Q2 is the number of classes in which the guide was taught. And the Q3, which is fascinating, was the number of presentations that teachers made to their colleagues on the material. So this was something that the teachers started to do spontaneously. It wasn't part of the project. But as they started to teach the material in their classroom, their colleagues in their schools became quite interested in it. And so the teachers actually had sessions for their colleagues. So what we were watching was a naturalistic horizontal diffusion of knowledge and an impact on the entire teacher community in the school, not just on the students who were being taught, but the teachers who had been trained. On the graphs on the right-hand side, you see the number of teachers that were trained over time. See the number of students. Q5 is the number of students approaching the teachers for a mental health concern. So again, we see this lovely impact by students before would never go to see a teacher about any concern they had related to mental health, and now they're actually doing that. And then we see in the dotted line, Q6, we see actually the referrals improving and increasing over time. So this remarkable impact that is sustained over a period of a year with enhancements of each of these solid outcome measures over time. So the next slide is I did mention that in Malawi we tried a peer educator model, and here the results in the peer educator model, we measured knowledge and attitudes, really substantive improvements in both. In the peer educators, unfortunately, because of the technical difficulties that we ran into, we were not able to measure the impact of peer educators on the behavior of students in their schools. So this is additional work for another time, but we are very encouraged that at least in the early phases of addressing a peer educator model, we have some positive results. So the potential exists that in the school setting to develop a mental health literacy framework that includes the technology, that's the radio programming, that includes the capacity building with curriculum resources and teacher training, and also then can include peer educator training as well, which really could booster and improve the capacity within any individual school. So as I said before, and I'm going to come to an end here so we can have time for Doug to speak and also to have some questions, but it's not possible to do this work if anyone thinks that you could do mental health in schools and not address the capacity to provide care in the community. You're thinking in Technicolor. In fact, it's really unfair to young people to start creating mental health impacts in schools and not be able to provide care when they need it, because they will self-identify, they will peer identify, and this is essential that we enhance community care capacity. So this is the model that we used. The schools that we intervened in were linked to community health care centers. And so then what we did is that we trained healthcare providers, all the healthcare providers in the community healthcare centers in the ability to diagnose, identify, diagnose, and effectively treat both psychological treatments and pharmacologic treatments, appropriate pharmacologic treatments for depression in young people. And just to give you some brief data, this again showed very positive results. The knowledge base for the healthcare workers, this is Malawi data, improves dramatically, and also their stigma, very important. The stigma that that healthcare workers have against mental illness goes down dramatically, as you see here, because their attitudes improve. Huge improvements in both components. And again, what we find in the Tanzania group is a replication of exactly what happened on the Malawi side. And we have significant improvements in knowledge, significant improvements in attitudes. That means decreased stigma. And that this is, as you can see here, highly significant, 0.001, with Cohen's d-value showing impact of 0.3 for attitude, which is just huge, and 1.0 odd for knowledge, which again is extremely high. And this is just from a couple of the clinics in the Tanzania model, showing that the flow is what one would expect. We're not getting overdiagnosis, we're not getting underdiagnosis, we're getting appropriate diagnosis. This is about the numbers that we would expect in a clinic setting, so that we are relatively comfortable that we are picking up many of the kids who would have depression, but we're not overdiagnosing kids who don't have depression. Now, what I'm showing you here on this slide, this article is coming out very, very soon. We actually also looked at what happened when the students went to the clinic. Did they get better? And we find here's data from clinics in Malawi. 93% of those who were diagnosed were treated. 7% were lost to follow-up. 75% of those were treated with effective helping, which is a psychotherapeutic intervention that we developed together with our partners in Africa. It's the first Africa-centric, specific psychological treatment for young people ever designed. It works pretty well, and the providers are also then able to use it because it combines cognitive behavior therapy, motivational interviewing, together with counseling techniques. They're able to use it not just in depression, but other places. And with the Department of Health in Malawi, and also the Ministry of Health in Malawi, and also in Tanzania, we were able to get rid of ineffective and potentially harmful medications for teenagers and replace it with the medication which is helpful and not harmful. And that you see, that's called fluoxetine, and we had about 2/3 treated with the medication. In terms of looking at their outcomes over time, we used a specific rating scale that we taught the clinicians how to use. 42% of the kids treated were much better, 42% better, 16% somewhat better, which is about what we would see in Canada or the United States or Europe in terms of outcomes for kids treated for depression. So these we're confident that what we're seeing is actually an appropriate impact. So now I'm just going to look at some of the challenges here. As I said, schools are necessary but not sufficient. We need to provide the education, but we also, when we're dealing with mental health, have to address the culture shift. We have to be able to reach students and teachers concurrently, and what we're able to show here is that this very simple approach does both. Because we also use radio outreach, we're able to address community stigma, community biases, which are also very important. But these all had to be linked to healthcare providers. We had to improve the knowledge and competencies of healthcare providers. We had to decrease the stigma in healthcare providers, and that was done successfully. And we also had to improve access to care. So we used a hub and spoke model, and it was very, very important here that the relationships between the headmasters in the schools and the local community clinic were key to young people who had been identified getting access to the care when they needed it. But the big question for us is sustainability. We know it works. We've done it. We've replicated it. We know it can work. So the question was, how can it continue? And I'm just going to quickly flip through these. These are just for you to look at later if you're interested in some of the published research on this, more to come. So these are just simply copies of papers that you can go and find and read details of some of the things that I'm telling you about now. So here is the sad part of the story. The positive part is that we were able to make substantive improvements in all of these things that we measured, that we were able to integrate community interaction with school-based interventions and clinic improvements, that we were able to show us that when you brought all these things together, you got a horizontally integrated approach, that schools were a necessary but not sufficient component of this, and played a huge role in addressing this, that improvement happened for students and for teachers. But, and these are buts that I'm going to talk about now, so we clearly know that a simple within schools only approach is inadequate. We also found that simple solution-based messaging is not adequate for mental health. It's not addressing HIV/AIDS prevention, wear a condom. It's not addressing simple hygiene. Mental health information is highly complex, and very, very simple interventions aren't appropriate for complex topics. So it was really, really key to this was we had to provide really good, solid education to the teachers so that they had the knowledge and they had the competencies to be able to impart this complicated knowledge to the students using existing school structures, and we provided them with simple resources to do that. We also found that single focus was not enough, and that's why we integrated radio listening clubs into the schools, which was a novel way of enhancing student interest, getting a lot of enthusiasm. It created a link to the community because the students' parents could listen to this at home, and it really engaged young people in wanting to learn more. We also were able to demonstrate outcomes, not just outputs, that we were actually able to show not just lots of people being involved in this or touched by this, but the actual meaningful outcomes in terms of knowledge, decrease in stigma, and changes in behavior, improvements in healthcare access, and actually getting better with treatment. We're able to show all these outcomes, and I'm just giving you the top line here, but it is some of the work here to actually address and do the research in many tiny communities far away from urban settings was very, very, very difficult. Huge challenges in the research. I don't want to underestimate the incredible challenges, some of which we had anticipated and many that we hadn't anticipated. And I just want to tell you that the work that the research teams on the ground did was just amazing, just absolutely outstanding dedication, incredible hard work, and stick-to-itiveness. But it was tough. We also want to highlight the cross-sectoral collaboration for outcomes for young people. Mental health outcomes is essential. Education and health have to work together. The schools have to be a primary location for addressing mental health for young people. So now I'm going to go to the last part in my thing, which I call failures, and I'm calling this sobering considerations, and I've said failures with a question mark. Sobering consideration, sustainability. When the project ended, the innovation ended, even though it was highly successful, and this is exceedingly frustrating because what it takes to actually sustain this is not much. So the sustainability framework and resources had been already developed. In each country, we had created master trainer groups who had the capacity to go and train teachers, who had the capacity to go and treat healthcare providers. They had all the training programs, all the materials that they needed to be able to do that. We also actually, in the last phase of the project, went into nursing colleges because we thought we could get pre-service clinicians and train them so that when they went out to the clinics, it would make diffusion of the knowledge better. We were able to demonstrate very clearly that nursing students improved their knowledge, improved their competencies, improved their skill sets, used what they had learned in their classes when they did their practicum in the clinics. But, and this is a huge but, there was no continued investment in either country to maintain either the Master Trainers Group or to maintain the nursing education intervention. The resources were all there. The resources are free. The resources were developed together with key leaders in both countries. The capacity building was all done. The human resources, the physical resources, everything available. But, and this is a huge but, there was no commitment to put in the small investment that it would take to scale out what was already an effective intervention. One of the challenges that we had in both countries was that it was much easier to engage the Ministry of Health than the Ministry of Education. In fact, in both countries, we were able to give direct input into the creation of new health plans and embedding the components of this project into both Tanzania and Malawi into new health policy. We gave all that input as the policy was being developed. To date, we've seen various drafts of the policies, but at this point in neither country has the policy been gone to the point that it's now become accepted health intervention policy, but it's encouraging. We were not able to, in either country, get the same kind of traction with the Ministry of Education, so no application of this material into teacher training or ongoing educational directions was available from either ministry. We had very good cross-sectoral collaboration between education and health at senior levels and at the district levels in both countries that happened during the project, but in neither country did the collaboration continue after the project ended. So the project was not successful in helping both countries develop the structures that they needed to continue the work that they were doing, the really good work, cross-sectoral work that they were doing afterwards. The project has attracted lots of international interest. For example, it was one of the top innovations presented at the WHO World Bank meeting. It's available on the Mental Health Innovations Network website. But that, even though that there is this good international interest, there has been no abilities to move the project forward, to scale it up and scale it out in either country, or to even continue in the sites that it was already proven to be quite successful. So there in a nutshell, we have a mental health literacy intervention, mental health literacy being foundational for everything that we do in mental health, clearly applicable in a low resource setting, able to do it, hugely positive outcomes for students and for teachers and for communities, but being unable to take it to the next step, and that is the scale up and scale out and maintain the capacity that had been embedded in the country. So overall, some really good successes, very good model, very good outcomes, but, and this is a big but, the question is how can this be sustained, and then how can it be scaled up? So that's the end of my presentation. Thank you everyone for listening. And I saw some questions coming in. I'm not sure exactly how to respond to those at this point. So if someone can direct me. Otherwise, Doug is waiting to add additional information here. So I'm going to sign off at this point.
Okay, thank you, Stan, and welcome to the question period. And we'll talk about this, and we need not get to the 2 or 3 slides that I had prepared in the time available. We can come back to it, although they do reflect some of the points that Stan's made. And maybe to start with the refreshing honesty, Stan, the conclusions about how to maintain or sustain something as like this in a school system is the challenge for all of us, not only in low resource countries, but for high resource countries. So there's lots of company we have in terms of moving from an innovative project to a program that's sustainable, and more importantly, a program that is sustainable within the context of the systems that need to sustain it. So so thank you for raising it as the key conclusion, and let's come back to that later on. One question I had, and I'll invite people to post more questions, is going to the entry point, to the starting point. And one thing that I took away from your presentation was that teachers were almost an entry point. Teachers are very concerned about the motivation of their students, about their mental health and their social development, because it impacts on their learning. And so I'm not surprised with your comment about how the teachers seem to really enjoy and ended up talking to their colleagues about it. That's actually the research on teacher development is indicative that that's how it happens from teacher to teacher. And so talk a little bit more about the teacher beliefs, how they got motivated in terms of getting involved in the program, and then is there a way that we might continue to build on that spark in terms of trying to have an ongoing spark for the decision makers and the systems people to really to get engaged in this.
Sure,
can you elaborate on that?
Yeah, sure. In order to get schools involved, we had to get permission from the Ministries of Education and from the various district authorities, which was forthcoming. And then what was very important was to get the headmasters involved, because in both countries, the headmaster plays a fundamentally important directive, operational, and leadership role in the school and within the larger system. And what we found as headmasters were approached, that by and large, I would say the vast majority of headmasters were either quite interested in wanting to do this, or at least willing, maybe not enthusiastic, but willing to give it a try. So I just really want to identify how important that relationship is with the headmaster. And then what basically was done was they invited teachers who wanted to participate to join, and they did get a good wave of wanting to participate. And then when the teachers were trained, and then they went back to their schools, we were not ready, and this is maybe just my lack of knowledge or my own failing. We were not ready for how many other teachers wanted to participate. It didn't take very long after the teachers who had the training went back and started doing these programs in the schools that we started to get inundated with headmasters saying, could you train more and more of our teachers? We just didn't have the capability to do that. So nothing succeeds like success. And what was happening, I think, is just as what you said, Doug, is that teachers were identifying that these were needs. And now all of a sudden they had tools. They had tools and they had knowledge and they had competencies that they had never had before. And they were using these and they were seeing results. And it was the results that were driving the enthusiasm. So that the whole way of spreading the information out within schools, the teachers just took this on themselves. They just started to have workshops in their own schools, inviting their colleagues who came in order to be exposed to the material themselves.
Okay, thank you. And we have a couple of questions about scalability and costs. Can you elaborate a bit on you were indicating the teacher training manual is free, but there must be other costs in terms of dissemination and also in terms of supporting teachers as they work with the model. Can you elaborate on the costs, say, per school or per local educational authority? Is there?
Well, I don't have a cost breakdown, but the costs are minimal. They are the training costs to train the teachers. Now, if you use a master trainer model, that then what happens is the master trainers will if you each country has a master trainer group. So that master trainer group can go and an individual from that group can go and train in a region and create a small group of sub-master trainers in that region. And that takes about 3 days for that group. And then that group can train out in the region. So your basic costs are the costs that you incur when you train. That's it. That's the cost, because all the resources are free. And each country already has its own master trainers. So that is simple. The developmental costs are all done, because the cost in terms of developing the resources, adapting them, and using them for for these different countries, that's all already been taken care of, so that the ongoing cost is simply the cost of using the master trainers and training the teachers. The other piece here, which is highly cost effective, is embedding this into pre-service trainee curriculum in the teachers' colleges, so that once you embed a curriculum and train a number of faculty, then you have an incredibly cost-effective impact, because as new teachers come through, they're taught this as part of their regular learning curriculum, and then when they enter the school system, they have already got the knowledge, got improved attitudes, and they already have the resource that they can apply directly in the school.
Okay, and then that goes to the systems issue of being able to embed this effectively within the initial teacher education programs in the countries. That's something that the FRESH working group on health literacy and health education is going to be working on, is trying to understand better how teacher education and development systems work, and how these kinds of programs can be integrated more effectively, or the knowledge and skills that teachers need can be embedded more effectively. So Stan, we may be calling on you more about that in the future. There's a question around, it's going back a bit, but I'm going to generalize on it. Sarah's asked a question about prevalence of depression, and you may want to respond to the question. It's in terms of burden of disease, but I'll also generalize it in this way. What are the measures that we need to look at in terms of measuring changes in student behaviors, in terms of help seeking, and help supporting, and also what their essential knowledge is? Going back to the mental health literacy model, is there a consensus that we can develop, or does it already exist, about what is the really basic learning that students need to acquire about mental health, about their own mental health, as they come out of primary or secondary school?
Sure.
And to what extent do we, and sorry to be long with this, but to what extent do we need to satisfy the medical or the health community concerns about disorders and medical things like depression, and how much do we need to satisfy the, say, I'll frame it as an education concern around social development and more psychosocial development? What's the balance between the two?
Yeah, sure. Very good, very good. So let me address Sarah's issue here, is that the burden of illness, depression, in terms of the burden of illness, it's not that there are hugely new numbers of people becoming depressed, but there is better identification for sure. But other disorders, the burden of other illnesses is going down, because they have now been much better early identification and rapid access to effective care, so that people are able to receive the care they need for those other illnesses much easier than they ever had before, and so that the burden goes down. What has happened for depression is that increased rapid access to effective care has not happened, and ergo the burden it will become a higher burden for that reason as well. So we have those two factors happening. The question about mental health literacy, it has actually got 4 components, and that's why I said it was foundational, and it doesn't ignore the psychosocial development pieces. So the 4 components are: number 1, learning how to obtain and maintain good mental health. And if people are interested, they can go to our website, which you see here on the slide, teenmentalhealth.org, and go to teenmentalhealth.org/curriculum, and you can pick up the online modules. The password to get into the modules is Teen Health, but instead of the letter E, use number 3, so it's T33NH3ALTH. And you'll see that there are 6 modules. One of the 6 modules addresses mental disorders. The others address the other components of mental health literacy. So there are four components of mental health literacy. One is learning how to obtain and maintain good mental health, and that's where all the psychosocial stuff comes in, where the health promotion comes in, into those mentioned. The The other is identifying mental disorders and their treatments. The third one is decreasing stigma. And the fourth is increasing help-seeking efficacy, which means knowing when and where to go for help, but also means having the necessary skills and competencies for self-care, and having competencies that you can learn so that when you do enter a health-seeking situation with a healthcare provider, you have skill sets that you can use in that interaction with your healthcare provider so that you will have much better probability of getting good healthcare. The measurements, Doug, are standardized. The measurements that we use are highly validated. They're used all over the world. Measures of knowledge, attitudes. Help-seeking can be measured many, many different ways. In this particular study, we've actually counted the number of students who had been identified and counted the students who had been referred. So we have that's a pretty solid measure of help-seeking.
Okay, thank you. And we're getting close to the end here, so I'm going to ask Alicia, or can I do this? Just go to that a couple of slides into the not the presentation, but the slides I provided to you. There's this one more. Keep going there. And this is go back. Sorry, that one there. Although. This is the challenge, I think, and I was reading through the systematic review done of mental health programs in low-resource countries done in 2013, and it's all over the map in terms of what we mean by mental health. And Stan, this may be going back to your comment about in high-resource countries we may have skipped by this issue of being able to focus on what are the parts that are more relevant to us. It doesn't have to, maybe has to be decided by country or by state or province, but the systematic review identified a number of studies, and they were all over the map about these different aspects of mental health. And so I think it's really important that we focus in on what exactly we're trying to achieve for all students around the world. And right now, at least from what in the scan that we're doing, there's more. You could put in more concepts under all those four headings as well. So there needs to be some sort of focusing in, perhaps at the country level, and then eventually at the global level as to what is the common denominator. Stan, do you have more of a comment on that?
Well, yes, and this is one of the frustrations which led us to go to the area of mental health literacy about a decade ago, because I could see not only here but in the work I was doing in low-income countries around the world that this was a problem. And the problem actually is bad enough in low-income countries. It's probably in some cases almost worse in high-income countries, where people jump on the latest fad and have the money to burn to spend it on useless interventions or useless components that then we cannot see that they change mental health status or mental health outcomes at all. You don't have that luxury in low resource settings, so you have to be really clear about what you're doing. Now in high income Western countries like Canada, we have been dramatically all sorts of mental health interventions, but we haven't improved rapid access to effective care for people who need it. So this is a huge challenge for us. Now, that is why we went to mental health literacy, because as a concept, as a construct with those four components, it captures all those different pieces, but it captures them from a way of enhancing knowledge, enhancing competency, so that you can address each of those important areas, but you do it from a position of strength, you do it from a position of knowledge. The phrase this whole spectrum, and I think that's why, Doug, you find so much confusion out there.
Okay, thank you. And that and I'll maybe just touch on the last phrase there, providing psychosocial support, and it relates to the comment that Sung Lee from Save the Children made as well. there is a discussion going on in a different context, one that's perhaps with more urgent problems, the context of countries and regions that have been facing conflict or disasters, and they're using the term psychosocial support quite a bit, and that sort of moves beyond the question of can we link this to services provided by the health care community, but rather to look at what can be done in the community setting. And long story short, because I think there's a discussion to be had about what is meant by psychosocial support is that the community engages, it wraps itself around the child and helps providing those kinds of psychosocial supports that can help a child who's falling through the safety net. So I guess, is that something that you found, Stan, in your work in these countries, that pulling together the resources within the community that are available, which may not be medically funded, but can still really help the child? Is that?
Oh, absolutely.
Were you able to connect to those resources?
Well, in where I'm sharing with you this data and this information, neither Malawi nor Tanzania are failed states, and neither are in a war zone and no famine, etc. So there are different situations in those places, and then there are different situations in disasters like earthquakes and tsunamis and typhoons and stuff. So those have to be modified, but these aren't either or issues, and to try to think of them as such is not helpful. So mental health literacy is necessary for everything. And in fact, mental health literacy teaches us that putting in mental health specialty services into disaster zones is not what people need. They need the psychosocial support approaches. But until we understand that properly, we're apt to make mistakes, and we're apt to invest in interventions which are either not needed or not helpful. So I think that the point made by Sung Lee is a very, very important one, and it's based on that differentiation from the mental health literacy framework that we have, that we bring to our understanding of all these situations.
Great, thank you. I'm going to ask Mohini Venkatesh, who is the chair of the Fresh Partnership and is always on these lines. Mohini, I think you had a little trouble getting on this morning or this evening, and wherever you are in the world. Can you just maybe close off the session and have a word about the other sessions coming up?
Thank you, Doug, and thank you, Stan, for that presentation and a great discussion on mental health programming in schools. Our next webinar is in a month from now, and it is, I believe, on the 15th of November, and we'll be commemorating World Toilet Day, and expect hear from us soon on the speaker and the topic. And thank you all for staying on today after the hour for the excellent presentation and discussion on mental health, commemorating Mental Health Day this month. Thank you.
Excellent, and thanks again, Stan, and to your colleagues who worked on the preparation of this, and thank you folks for your attention. If people could remember just to click off, I'm not sure if the tape, Alicia, the tape is probably stopped at this point, so that's great. And we'll be posting the full recording on the Fresh website and on the Schools and Health websites as well. Great. Thanks again for participating.
Thanks, everyone. Bye now.
Bye.